Well, thank you very much, Sue, for asking me to give this lecture today. And it's going to be a to and fro lecture. I'm going to have things to talk about, and then I look forward to the questions at the end. I have been here at Baystate Medical Center. I've only had one job in my life. I mean, one job as a physician, and that's after fellowship and internships. That's here at Baystate, and I've been here since 1982. And if you do the math, that's 42 years. So, and I've really, really enjoyed myself. And ever since I've come here, even before I came here, I've had a passion for doing things with sickle cell disease. So I am a hematologist, and I am the medical director of adult hematology here at Baystate. And I specialize in all sorts of blood conditions, but one of the things that I truly have a passion for is sickle cell, understanding it and socioeconomic issues with it and the disease itself. So, and like it's such a timely time to talk about this because like you said, Sue, this month is Sickle Cell Awareness Month. So I don't have any slides, and I'm going to just talk. And so save your questions for the end. But this is a very simple way of thinking about sickle cell, and I will discuss the physiology of it in a little bit. But just imagine looking over your back, to the Connecticut River, and make believe that that's a blood vessel, and make believe that like little floaties are going through there, and those are the blood cells. And if they come to a narrow part, they can sort of deform and they can bend and they can get through there. In sickle cell anemia, we're going to talk about a single abnormality of a gene that renders it unable to deform. So instead of being like round little donuts, being able to go through little crevices and stuff and narrow parts of the Connecticut River, they're like logs stuck in these forms, and they're going to get stuck. And everything downstream is going to be robbed of blood and therefore oxygen, and it's going to cry out in pain. And since blood goes all over your body, every place from your head to your toe can be affected with sickle cell. So as I get deeper into this, just remember that analogy as we speak. But one thing I did in preparation for this talk is a little bit about the history of sickle cell. I think the history of medicine is pretty interesting. And so let me give you a tidbit on the history of this condition. So it was in 1904, there was a gentleman from Grenada, which is an island in the Caribbean, and he went to dental school in Chicago. So he took a boat from Grenada to New York City, and then I don't know how he got to Chicago, but he got to Chicago, and probably took a car or something like that, and or a train. And off he went to Chicago. And in Chicago, he got sick. He developed a leg ulcer, which you'll see is a manifestation of sickle cell, but the disease was never described at that point. And then he would get recurrent pneumonias and chest pain, which is also a manifestation of sickle cell. And it wasn't until 6 years later that an internal medicine doctor at Chicago by the name of Dr. Herrick was able to describe this, and he looked at this gentleman's blood. Dr. Noel was the gentleman who was the dentist, the patient, and they saw the sickle cells, and the sickle cells, which basically look like sickles, like when you're going to cut down hay and stuff like that, is when it was first described. Well, the good news is that this gentleman was able to graduate dental school, and he went back to Grenada, and he opened up a very nice dental practice there. But unfortunately, at the age of 32 years old, he passed away because he had a sickle cell crisis in his lung. Okay, so that's the history of sickle cell and when it was first described. And a lot has happened since that, and a lot hasn't happened either, and a lot more needs to be done. But hemoglobin, is the pigment in a red blood cell that makes it red. And the only job of a red blood cell is to carry oxygen. So there's different kinds of hemoglobin. One of them is called hemoglobin A. Another one is called hemoglobin S, which comes from the sickle cell. And then there's a fetal hemoglobin. And we need to talk about those in a little bit of detail. So hemoglobin A is basically the stuff in the red cell. It's hemoglobin, and it leads to a normal hemoglobin. So those cells that were going down the river are very pliable, and they're like donuts, and they can bend because the hemoglobin will contract and bend, and it gets all the way, from the lungs to all parts of the body. Whereas with sickle cell hemoglobin, they're stiffer and they get stuck in the river. If you happen to have what is called sickle trait, you have a little bit of hemoglobin S and you have a lot more hemoglobin A, and you have the ability to pass that on to an offspring. And I will tell you a little bit about that in a second. But people with sickle trait generally don't have any medical problems at all. Now, if they flew in a airplane and a window popped open and they were depressurized and stuff like that, then they could develop a sickle cell crisis too. But generally here on Earth, they're pretty well protected, and there's really no issues with patients with sickle cell trait. Hemoglobin F is the fetal hemoglobin that protects you while you're still a fetus. And then over the 6-month period, the fetal hemoglobin gradually drops and the hemoglobin A increases or the hemoglobin S increases. So it takes about 6 months for sickle cell to basically show itself because the hemoglobin F is a protector. And when we talk a little bit about protecting and treating sickle cell in a little bit, you're going to see how there's pretty cool ways of increasing the hemoglobin F that may make the disease better for a person that has sickle cell anemia, but not as a fetus, as an infant, but as a young adult. Okay, so how does the genetics of this work? Okay, so I told you that there's a single gene on a chromosome that codes for these different hemoglobins. Okay, and it takes two to tango. So if there is a mother that has sickle trait, so has the A and the S, and a father that has a sickle trait, the A and the S, then every time they have a child, boy or girl, there is a 25% chance that the child could be totally normal with AA hemoglobin, so no sickle cell at all. There will be a 50% chance that that child could have sickle trait, could pass it on, but clinically would have no medical problems whatsoever. But there is a 1 in 4 chance that the baby could have sickle cell anemia. Okay, so it takes two to tango. Okay, now in terms of how common are these genes? Well, the gene is present in 1 in 12 individuals of African descent. It is seen in the disease. So the trait carrying the gene for sickle cell is seen in 1 in 12 Africans or people from African descent. The sickle cell anemia is seen in about 1 in 400 or 100 in 500 individuals of African descent. But sickle cell anemia is not just seen in Blacks and Afro-Americans. It is also seen in Hispanics, people from India, Caucasians, and people from the Mediterranean. So the gene is present in about 1 in 1,600 people that are of Hispanic background. So it is not just a disease of Afro-Americans, okay? There are about 100,000 cases of sickle cell disease, which is what we're going to talk about primarily today in the United States, and about 8 million in the world. So it is a condition and it's not going away. So why does this gene keep on propagating? Sometimes Darwin would say that, the survival of the fittest, that this is not a good gene. Sickle cell anemia is not a good disease. Why doesn't it just, go away? Well, it turns out people that have sickle trait, particularly in sub-Saharan Africa, are protected against malaria. So one thought is that the gene is protective, not sickle cell anemia so much, but for sickle cell trait folks, they're protected from having malaria. So for survival of the fittest, they do better with having malaria than, let's say, a person that doesn't have sickle cell trait. So let's go on to how is it diagnosed? Well, I'm old enough to know that in the olden days, it wasn't diagnosed very well. And we would have like fairs at grocery stores or at schools. This gene is so common in the Afro-American population and Hispanic population to, test everybody and see if anybody has the gene, and then you can sort of plan your family moving forward. Well, now since 2006, and I was on the committee here in the Massachusetts that started this, and then it really went throughout all 50 states. So there is an entity known as newborn screening. So every time any baby is born of any color, of any ethnicity, they do a heel stick and they test you for all sorts of things that they test babies for, PKU and other disorders and things like that, Tay-Sachs disease, but everybody is tested for sickle cell too. So within a couple of weeks, that test is known, and family and doctors are notified if you have sickle trait and are notified if you have sickle cell disease. And then the pediatricians can take over taking care and educating individuals with both of those conditions. Okay. So life expectancy, that has dramatically improved with treatments that we're going to talk about in the second part of this talk. But in the very beginning, so many babies that with sickle cell disease, and before giving penicillin for prevention, which is very common to develop overwhelming infections in sickle cell babies, were dying. And by giving penicillin prophylaxis preventatively to prevent these infections, most of the babies are not dying anymore and are living well into adulthood. I have a couple patients here that are in their 70s with sickle cell disease, but the average age or lifespan of a gentleman is in the order of 50 years old, and in a woman, it's like 55 to 60 years old. Individuals with sickle trait will have normal lifespans. Okay. All right. So how does sickle cell present itself? So before we go on to some of the treatments that are out there, let's just talk a little bit about how it can present itself. And like I started off this discussion, we talked about the Connecticut River, we talked about the formability of red cells going through, and then we talked about the sickle cells, which is like a red cell, like a round donut, and you stick a log in it and it just doesn't move and it looks like a sickle cell. So when I see a patient with sickle cell, I basically just look at their head to their toes, and I know that everything from their head to their toes and in between can be affected, okay? And it's very heterogeneous. So you could have a person with sickle cell disease that comes and see me once a year or almost like once every 2 years, and one who would be coming in much more frequently with sickle cell pains and stuff like that. But let's talk about that next. So even though you have sickle cell disease, it can vary in its intensity and its presentation entirely. So infections, as we talked about, are common in children. Penicillin prophylaxis has basically made that go away. Dactylitis is common in children, but you don't generally see it in individuals over the age of 3 to 5 years old. So what happens is down the river, they get bony infarcts or they get blockages with their sickle cells in the lining of the bones. So not in the bones itself, but if you were to eat, like take a chicken bone or something, and you break it in half, you know that there's the bone, the brown stuff in the middle, which is the bone marrow, and then there's the bone that cracks, that's the white bone. And on the surface, sometimes there's like a thin piece of cellophane. And that has a lot of nerves in it. And the sickle cells can cause the cellophane to die, and particularly in the hands and the feet. And it can be one hand or in one foot, or it could be both feet, and that's called dactylitis. And that can be very disabling in little kids. And growth can be delayed, and puberty can be delayed in little children too. So when I look at your head, there is a higher incidence of stroke, and for the same reason we talked about the red cells going down the Connecticut River, they can cause clog up in the brain and cause stroke. And unfortunately, the median age at which one gets a stroke with sickle cell is about 7 to 10 years old. So it's not like an older person who gets a stroke when they're 70, 80, or 90, but they're quite young. And then when you have one stroke, you're prone to developing more. So there are ways to try to prevent that. Another thing that can happen in sickle cell, but it's much less common now, is meningitis because there's a higher incidence of infections. You can get meningitis. The backs of the eye, known as the retina, can be affected with sickle cell, and therefore it's very important with all sickle cell patients, not so much the traits, but all sickle cell patients to go to the eye doctor at least once a year, even if they don't have any eye problems. So moving down, so in the chest, there's a higher incidence of pneumonia, and we talked about infections, but there's also a disabling condition called acute chest syndrome. And this is basically sickle cells blocking up little parts of the lung, and it makes you have tremendous amount of pain. And if you take a deep breath, it really hurts. And if they put that little thing on your finger to check your oxygen, they know that it goes way down. And there's treatments for that too, which we're going to talk about under treatments. So in the lungs also, if you have enough of these little infarcts or little death of the lung repeatedly, you can get what's called pulmonary hypertension. And that can lead to pressure on the heart and can lead to heart issues too. The blood vessels to the heart are flowing so quickly that it's pretty darn rare to see a sickle cell patient develop a heart attack. But because they're anemic and the blood is pumping so vigorously, their hearts can be dilated, but they don't generally get heart attacks. Down in your, I'm skipping, well, we'll go to your abdomen. So in the abdomen, there's your spleen. The spleen protects you from infections, and the spleen, which sits in the left upper part of your body, is a garbage can for old blood cells to be revitalized. And the spleen dies by the time you're 5 years old with most patients with sickle cell. So you lose some immunity there as well. And because old blood is recycled and goes to your gallbladder, which is near your liver on the right upper quadrant, there's a higher incidence of gallstones in patients with sickle cell disease. Okay. Now let's move down to the hips. So if the bones can take a hit from these cells going down the river and clogging in the bones, and so aseptic necrosis, which is death to the bone, particularly your hips, it can be your shoulders as well. It's pretty rare to be your elbows or your knees, and so you'll see people that'll have bony infarcts or death to the bone, and bone infarct after another will lead to pain, which will lead to chronic pain and flattening. So normally it's a ball and socket in your hip, and then imagine the ball is not so round and the socket is not so round, and it starts to wear and tear. So sometimes we'll see sickle cell patients requiring hip operations and hip replacement surgery at young ages, like in their 20s or 30s, where generally we see that in people that are in their 70s to 90s. Okay. There is a higher incidence of blood clots in patients that have sickle cell too. So this is something that's sort of new. And this is not blood clots in the arteries like the river, but blood clots more in the veins, like a DVT or a pulmonary embolism. And we have to watch out for that as well. So what happens during pregnancy and sickle cell? Well, because of the infarcts to the placenta, the babies can be smaller than their gestational age, and there is a higher incidence of miscarriages in patients with sickle cell. Okay. So, but the biggest thing that I omitted so far is what brings the sickle cell patient to the hospital time and time again. Any one of these problems can be a problem, and none of them are rare. And they can all just happen one at a time, and they can all happen together. And the organs can be involved too, including the kidneys and the liver and things like that. But the biggest problem that you probably have heard of is called a sickle cell crisis. So there was a time a while ago that we didn't like to call it a crisis because crisis had a bad connotation. But to any person who has sickle cell disease and has had a sickle cell crisis and not just had a sickle event, they want to call it a crisis because it really does hurt. So if you ask a patient with sickle cell, how does it hurt? I've heard all sorts of things like pressure, but most of the time it's like knives going into you that most of us can't even imagine. And it can be all over the body, but it's primarily in the arms and the legs. It's very rare in the brain. It can happen in the chest, like we talked about acute chest syndrome. And the treatment from that 1904 gentleman with sickle cell to now hasn't changed much. There's a lot of upcoming great things that I'm going to talk about rather quickly, but the point is giving fluids, more fluids to wash those sickle cells down the river is something we do with hydration. And because this hurts so much, pain medicines is another thing that we give patients with sickle cell. And it can be hopefully a Tylenol or an Advil, but sometimes it has to be narcotics. Getting to the pain again, it's wonderful if there's other things that we can use other than pain medicines to make them go away. So yoga is a thing that we can use in sickle cell. My daughter is actually a yoga therapist and has trained some of our sicklers here in Springfield. She lives in Colorado. In terms of meditating and doing yoga, mind over matter, to make the sickle cell better. Sickle cell is worse in the winter, oftentimes than the summer, because the blood vessels constrict and the river gets narrower. And so keeping warm and taking warm baths can be an option as well. And those are some of the non-medical things that we try to teach. And it's easier to teach that than to really preach it, because what happens sometimes if you're in pain, it's very hard to focus on yoga, and it's very hard to meditate. So what brings on a sickle cell crisis? Why do some of the sickle cell patients come into the hospital so frequently and sometimes for so long? Well, the things that bring it on, the most common thing is, I don't know. And nobody knows what brings it on. Why do these sickle cells stop flowing? Why do they get stuck to the beaches, let's say on the side of the Connecticut River? It's unclear. But cold can bring on a sickle cell crisis. Illegal drugs. Some are not so bad, but some can be bad. For example, cocaine can make your blood vessels constrict and can bring on a sickle cell crisis. If you drink alcohol, this is fine. But if you drink too much and then you urinate and then you get dehydrated, that can also make the blood thicker and the sickle cell and bring on a sickle cell crisis. What we've learned over time is exercise is also good, but to a point. Don't get dehydrated. And menstrual periods, premenstrual periods can really precipitate a sickle cell crisis as well. Okay. So let's focus now a little bit on treatment. So as we talked about, for many, many years, the treatment of choice when a patient comes into the hospital with any of these problems besides antibiotics is, what can we do to push the cells down the river? So it's IV fluids, okay? Sometimes you can give so much IV fluids that your heart can't take it, and then you get heart failure, and that's an issue. So you have to be very careful when you push the fluids in a patient with sickle cell. The other thing we often will do is pain medicines. And this I mentioned in that little one of the questions that I answered is that when people with pain come to the hospital, sickle cell patients with pain, many people think they're drug seeking, because they do have to use narcotics many times to break the sickle cell crisis and get it under control. But most, if not all, are not drug seeking, and they have real pain, and you have to believe, and then you can take it from there after that. So you're really cutting the edge between using the drugs for pain and then abusing the drugs. And most of them, I'm saying to you, are using the drugs. And when you go to emergency room after emergency room and time after time, it's very common for doctors and nurses to think that you're abusing. And I can tell you that you're not. Um, but that was the treatments of choice. And now in 1998 came a medicine called hydroxyurea. It's an old medicine. It's a type of a chemo pill, and that would scare a lot of people away, saying, I'm not going to take chemo. But we know that hydroxyurea makes the sickle cells less. It increases that fetal hemoglobin. Remember, we talked about babies are protected for 6 months because they have this fetal hemoglobin that's trending down. Well, what can I do to bring it up? And hydroxyurea, it's an oral pill a couple times a day, can make the cells bigger and make them sickle less by increasing the fetal hemoglobin. And it also suppresses the blood counts a little bit. So you're making less sickle cells in the bone marrow that get into the blood, and then they become a little bit less sticky. So most patients should be on hydroxyurea. And as long as you're over the age of 6 months old, it comes in a liquid form, you should be on hydroxyurea. And you should be on the hydroxyurea enough to suppress some of the blood counts, not the red count, but the other counts, the white count and the platelet count, to a degree that you may be benefiting the patient. And it can clearly help with pain. And it can clearly decrease hospitalizations, and it can clearly decrease chest syndromes, and it decreases people who need red cell transfusions from time to time. But there's a lot out there that say that they have side effects to a medicine, like anybody can have a side effect to a medicine and doesn't want to try it. And then there's this whole thing where it's a chemo pill. If you Google it, I think you'll come up that we use it in other blood cancers. And sickle cell is not a blood cancer. And then that can shy people away from using it too. Some people, though, have such mild disease, as I said, that we don't need to use the medicine in those individuals. So we had to wait 20 years in the late 20, like 2018, for some newer medicines to come about. And they're very cool the way that they work. But the bottom line is they're good, but not great. So one of the medicines is called crizanlizumab. And what that does is it's an infusion once a month, and it's supposed to make the sickle cells less adherent to the vessel wall. So the sickle cells flow down the Connecticut River smoothly. They're not going to get stuck to a beach, at Six Flags, and get stuck to a beach in Longmeadow, and then everything downstream gets robbed of oxygen. The problem is that we were very excited about this. It was a very new mechanism by decreasing the stickiness of the sickle cells, but a European study came out and says that it really wasn't that effective. And so now this very cool mechanistic drug is really very rarely used. There's another medicine called Endari, and when a sickle cell sickles and then blows up and sickles and blows up again, in the lung it blows up, and in the toes it sickles, it can lead to oxidative stress or stress with sickling and stuff. And so Endari basically is a powder that you have to mix in juice twice a day to try to inhibit some of that sickling by reducing the stress. But again, it was expensive. It's come down in price. It's called L-glutamine. You can get something like that at GNC, but not the potency that they have. And most of the sickle cell doctors don't think that that's a home run either. And when it has been prescribed, you have to mix it in liquid and drink it, and it doesn't taste so good, and you got to do it 2 or 3 times a day. And that's enough for a teenager or 20 or 30-year-old to say, no thanks. Then there's another medicine that's come out called voxelotor. And voxelotor basically has been shown to increase the hemoglobin. So it increases the hemoglobin in the body, so that you sometimes need less blood, less transfusions. And by increasing the hemoglobin in the body, since the job of hemoglobin is to carry oxygen to all parts of the body, and that's only good in sickle cell, it's shown to do just that. What's the downside? Not much help in making some of these crises and some of these side effects that we talked about already better. So 3 very exciting drugs, And we still use them, but some of them are waning and not being so effective anymore. So the last part of my talk is going to be exciting, and that is, what can we do to cure sickle cell disease? And can it be cured? And the answer is yes, it can be cured. So let me take you back. So there's only two ways to cure sickle cell disease. One is a stem cell transplant or a bone marrow transplant. I will describe that in a minute. And then the exciting parts that just came out in December of 2023. Both of these companies are in Cambridge and in Boston. And these are very cool ways of gene editing and gene splicing and putting normal genes next to sickle genes or increasing hemoglobin F and making the disease better. So let me give you an example of how to cure sickle cell disease, okay? The first one was 40 years ago. There was a little girl, and she had sickle cell disease, and she also had acute leukemia. So she had acute myelogenous leukemia. And the treatment for that part of at that time was to treat her leukemia was with a stem cell transplant. Okay. So her brother, who had sickle trait and was fine, was the donor. And the girl had to go into the hospital and get chemotherapy to knock out her bone marrow. That's the factory that makes the blood, red cells, white cells, platelets, and sickle cells. And her blood had to be wiped out to make room for her brother's blood to come in. Okay. And sure enough, that all happened. And it's not a walk in the park. And there's issues that I will talk about in a second. But at the end of the day, at the end of 3 or 4 months, that little girl was cured from acute leukemia, and she was also had no sickle cell because she had her brother's blood, and her brother had sickle trait and had no disease. So she recently died, but she was like in her 70s or 80s, and it's a cure. But most doctors are not transplanting sickle cell, but there is more and more happening with sickle cell. Most of the time, you do bone marrow transplants or stem cell transplants for cancer diseases, but it has been shown to be effective for sickle cell too. But it's if you have to, so you have to get a match, and it usually has to be a sibling match. So it has to be a brother or sister. And in the Afro-American community, which is most of the patients in the United States with sickle cell, but not all, as I mentioned, the only 10 or 15% chance that a sibling will be a match. So you can have a transplant from that family member, okay? The other thing is the donor, it has no problems. But remember now, I have to give you chemo, forget the leukemia, to knock out your sickle cells. And then what happens is we get stem cells, which are like mommy and daddy cells that can grow up in your body. So in other words, we take them from the brother, from the donor, and we put them in a little bag and we infuse it like a transfusion into their arm. And in 7 days, the transfused blood, the brother's blood in the patient with sickle cell doesn't like the blood and wants to nuzzle up in the bone marrow, which is the factory that makes the blood, and starts to grow after 7 days. And that's called engraftment. What are the complications that chase people away from doing this? Well, everybody with all this chemo gets infertile. So you are in your teenage years or even younger or 20s undergoing this curative regimen and you're infertile. So there are ways now of trying to do an egg harvest, so put that away, or a sperm harvest and put that away so that kids can come in a little bit later. There is hair loss. There are transplant-associated morbidity, which has to do with infections while the blood counts are very low. And a lot of people that I have taken care of over the years with sickle cell says that, I have sickle cell. It is not a walk in the park. It is not fun. But you know what? I'm living with it and I'm going to do pretty well with it. And there's a lot of mind over matter with it. And you know what? I think I'm going to put that stem cell transplant on the side. Okay. And most of the time, they can't even do a stem cell transplant because they have to get one gene that matches. And in the donor pool, for Caucasians, there's so many, but for Hispanics and for Afro-Americans or people of African descent, there's not that many donors to pick from, so it's harder to do. So the part two and the sort of the conclusion of my talk is what can we do in those individuals and still talk about cure? And this is where these companies that are in Boston come around, okay? Because it's so hard to find a donor for a stem cell transplant, what can we possibly do? So let's say there's two things that we can do. One is called gene therapy, and one is called gene editing. And both of these are ways of basically taking, remember now, there's only one gene in a chromosome that makes sickle cell. One little gene makes this whole hot mess that I'm talking about right now. And what can we do to fix that? Well, let's say this is a gene in a patient with sickle cell, and this is the sickle cell gene. Well, I have a way of putting in another gene right next to it. We'll call this is the sickle cell gene, and this is the hemoglobin A-like gene. It's not exactly A, but it's A-like. And then it's survival of the fittest. They're now put into a patient with sickle cell, and I'll explain this in a second. And then the sickle cell gene is still present, but all of a sudden the patient starts looking like they have sickle trait. They have more of this A gene than the S gene. So how does that happen? So we have to take the patient's blood and we have to send it to a laboratory, and it's not that far because it's in Massachusetts, and we can put in this gene into their stem cells, okay? But then the patient has sickle cell anemia and will reject this in a heartbeat. So then this patient who doesn't have a donor, this is the big plus part about this, will still have to get chemo and will still have to go through infertility and hair loss and problems with getting chemotherapy. But that prepares them for getting their new blood infused. And the new blood infused will be just like that's like patient with leukemia, like the brother. It'll be sickle trait. It'll have the sickle gene of the patient, but it'll have this transfected gene, this other good gene right next to it, which will take over and grow. And it's like 90% effective. And the people have to be over the age of 12 years old. And the indications, it's better to do if you're a child than an adult. But if you have recurrent problems with chest crises or an increased risk of a stroke or pulmonary or renal disease, you can undergo this. And there have been a handful of people, they're really handpicked to do this. The downside, I told you, is infertility. Even giving the chemotherapy to prepare the bone marrow for this new blood to come in and grow can cause leukemia down the road. It's pretty rare, but it's been reported. So can you imagine having sickle cell going for a cure and then a year or two later having leukemia? But that's not common. And the cost right now for that, so it's happening, and there is gene therapy out there, and it's getting more and more popular. But it's right now it's $2 to $3 million. Nobody can come up with that money, but the government and Bud Williams here in Massachusetts and the government of Massachusetts and the country is working with ways for combat the infertility and make this more affordable for everybody with sickle cell who is handpicked by their doctors to undergo this procedure. Okay. The other way of doing it is here's your sickle cell gene, and here is the hemoglobin F, and it's sleeping. I can put something next to the F to stimulate the F. And remember, I told you when the hemoglobin F or fetal hemoglobin makes the sickle cell gene sort of disappear and makes the sickling go away. That's the other way. So we can take that out of the body of a sickle cell, send it to Boston or Cambridge, get them to put that gene in there, increase their hemoglobin F, prepare their body by giving them chemo and wiping them out like dirt, and giving them this new product, which after 7 days will grow, and then you will have this new gene therapy taking place. And again, there's been more than a handful of patients that have done this. And if you do Google it or look at, you can see on YouTube, YouTube, you can see these individuals that have just changed. I mean, from sickle cell anemia, debilitating to cure. So there's a lot of cutting edge treatments. There's a lot of trials. We're still stuck with the hydration and the pain medicines. And at this point, I'm pretty well done with my talk. And I welcome any questions. And thank you again for letting me talk.
Thank you, Dr. Steingart. Thank you for what you're doing for these patients who really need your expertise. And thanks for a great presentation. There are a number of questions in the Q&A box, and we invite anyone that has any questions to include them. Generally, the Q&A box is at the bottom of your screen, and you can just click on it and type in your questions. And we'll start with the first one. The first question is, maybe I misunderstood. I thought babies kept F for 6 months after birth, which would make the heel stick not work. Can you review?
Yes, so that's a very good question. Actually, every question is a good question. But the point is that with the fetal hemoglobin, it's not 100% fetal. So it's like 60% fetal, and then there is your A and there is your S. So we're able to see the F, you're right. And we're also able to see the A, which is normal hemoglobin, and the S. So we can pick out the F, subtract that, and tell if you've just got A and S, at which point you have trait, or you just have A, at which point you're normal, or which point you have S, at which point we call the patient and the doctor and say you have sickle cell syndrome. So it's not 100% F. Yep.
Thank you. The next question, what's the difference between sickle cell disease and sickle cell anemia?
Nothing. They're the same thing.
Very good. And
that's another great question.
Excellent. The next question, can you spell the itis that impacts the lining of the bones?
Yeah. Oh my God. I didn't win my doctorate in spelling, but I will try. So dactylitis, DACTYLITIS.
Excellent.
Very good. Know if it's right. I think it's right.
It sounds great. And referring to that last question about the itis, they're wondering how common is it in children?
Probably under 20% of children with this condition will have dactylitis.
Very good. The next question, do we currently have, and they're referring, as we, they mean Baystate Health, do we currently have any patients doing a transplant? And if so, how are they doing?
So I have sent patients for transplant. They're very picky in who they take, depending on their frequency of crises and requiring of pain medicine and end organ disease, in terms of strokes and heart and things like that. So for the 5 or 6 patients that I've referred, nobody has been accepted. And so nobody here that I'm aware of in Springfield, the patients that I take care of, have been accepted. The one thing that I can flaunt about Baystate is we have a really terrific pediatric hematology service as well. And Dr. Ludi sort of is my counterpart for kids. And we transition the kids to the adults really well. So I start to see the kids when they are on the infants and children's floor and then transition them to adulthood. But I don't think she has any patients that have actually had a transplant either. And this whole thing with the gene therapy is just opening up in the last 6 months. So stay tuned. That's why I think I'm talking about this today.
Excellent. That is so encouraging. The next question, are gene therapy and gene editing different?
So they are. So what I wanted to get across, and maybe PowerPoint would have been better, but here comes my fingers. So here's the sickle cell gene, and next to it is nothing but sickle cell. But here we're going to take this blood out of the patient and send it to the lab. And I'm going to put in, just like typing and just editing out a sentence and putting in another one, I'm going to put in hemoglobin A. So I told you in the very beginning of this talk, if I have A and S in the same cell, I'm going to have sickle trait. And I'm going to have more A than S, and that will make the patient's disease or sickle cell anemia disappear. That's one, okay? That's called gene editing. That's called gene splicing. Gene editing is different. Gene editing means that I'm not just treating by putting in an A gene here. Here's the sickle, but what I'm going to do is here's fetal hemoglobin and it's sleepy. And if I can do something to wake up that fetal hemoglobin, then it can suppress my S and they can be fine too. And both of these techniques have been working. So I don't put in a new hemoglobin A gene. I put in something that stimulates hemoglobin F. That's another gene that stimulates hemoglobin F, and that's how that works. And that's called gene editing or gene splicing. That clear?
Terrific. Yeah, no, that was excellent description. The next attendee just wanted to thank you very much and said that it was great information.
Thank you.
The next question is, the stem cell transplant and the hemoglobin F transplant seem to work very similarly. Is one more effective than the other?
So, for the gene editing and the gene, so we don't know that yet. Okay, we don't know that, and the trials are picking one or the other. So this is so in its infancy, and just like we learned about some of those hoo-ha drugs that I talked about that have crashed and burned and not been so great. I mean, I think this will be the way of the future, but we don't know which one is going to be the better one to go to. The advantage is that you don't have to have a donor. You are your own donor. We're putting new genes into your blood, so I don't have to have your brother or your sister that's going to not likely have a match, or somebody out in California, that's not going to have a match. I can use yourself. But which one is better is unclear. They're both when they take, and there's no complications, they're both highly effective, over 90% in both.
Wow. Wonderful. The next question, which treatment can you give it to an adult client in serious pain with HB 6.6G/DL?
Okay, so patients that have sickle cell anemia or sickle cell disease will be anemic. So the normal hemoglobin for an adult male is like 15, and for an adult female is like 12 to 13. And most of the patients with sickle cell will run hemoglobins of around 6 to 7. And that's where they live, and their body is used to that. So every time I transfuse somebody with somebody else's blood, I have a couple of things that I can do that aren't so good. I can give them iron. There's a lot of iron in red blood cells, and sickle cell patients need iron like a hole in the head. The other thing is there's a rare chance that you can get infections. I mean, AIDS and hepatitis are still tested for, and it's very rare, but it's still possible. And then the other thing is you can develop antibodies. So let's say Sue gives me blood or something. My body may not like her body, and I can get antibodies to that. And if I just give blood to raise the hemoglobin from 6.6 to 7, am I doing you any good? because if you get antibodies and you really need blood, let's say your hemoglobin is down to 3 or 4 or 5 and you really need blood and you have antibodies, I can call the Red Cross, I can call all over the place, and I can't get blood for you. So we don't really want to do that. So at 6.6, if that's where you're happy and your body lives, that's what I'll do. If somebody that's not a hematologist sees a 6.6, the first thing they'll think is like, what can I, let's give her or him blood.
Very good. Thank you. The next question, are there any lifestyle choices you can make to help manage the disease?
So I'm begging to have a social worker work with me for my sickle cell program here. It's a little bit of a one-man show with me and Ludi, a two-person show, but half of sickle cell is me and the disease and treating the pain and taking care of all these side effects and things like that. Half of the sickle cell is at home, in the community, interacting with friends and family, socioeconomic problems and things like that that can arise. And we need help to deal with that too. I can't do everything. I try, but that's really important too. So this whole thing that of yoga and meditation and exercise and positive. And if there's an older child with sickle cell, what they can go to camps and stuff like that, the hole in the wall camp and stuff like that in Connecticut, where the little guys can come in and learn from an older person with sickle cell. That older sicklers love to teach and about their disease to the little kids that are all ears and so receptive.
Awesome. And I do wish you luck on that endeavor. The next question, so the best options for treatment all involve chemo?
No. So, I mean, in order for a stem cell transplant and in order for any of these gene therapy things that we're talking about, yes, because I have to make the bed, I have to strip the bed, I have to take the sheets off and the covers, I have to make your bone marrow with sickle cell all nice to get this new blood into you. So I have to take all your blood out, and all the way we can do that is with chemotherapy now. That is true.
Very good. The next question, is exa-cel available anywhere for sickle cell disease? And they have it spelled EXA-CEL.
So that's an amazing question, because we're going to have an in-service on that. One of the fellows that I'm training wants to do a morning report on that on Friday. So thank you for that question. I have the article in my briefcase. It was in the New England Journal this 2024 in March, and I still have to read it. Okay, it is still along the line of stem cell transplant and gene editing. But whoever that is, give me your telephone number, and on Monday, after I have that conference, I can tell you exactly what's involved. But it is going to be a combination of chemo, making the stem cells ready to be better for transplant.
We just have one more question and then one more statement. Why would a provider recommend gene therapy -editing or stem cell?
So it has to do with if you have, for example, so there's a whole lot more data and experience with transplant. And I told you about that with 40 years ago, that little person with leukemia got a home run, cured the leukemia and the sickle cell. So that has gotten better and better and better, less toxic chemo and less graft versus host disease and much better. The problem is with the stem cell, we have to identify a sibling matched. So a brother or a sister, sometimes either a mother or a father, that would be the best match. So that is sometimes, if that's identified, because there's so much experience with that, they can do it blindfolded in Boston. I mean, it's easier to do. But I told you that only 10 or 15% of families have siblings that will match. And in light of that, we're looking towards the other possibilities too. But a stem cell transplant would be preferable now because of the experience, but you have to identify the donor.
Thank you. And just to end this part of the Q&A, this attendee says, "Thank you, doctor. I'm a nurse from Gambia, and I'm grateful to attend your webinar. And I applaud your work, Dr. Steingart, and for sharing all this information and for helping these patients clearly in need. I hope that and pray that we find a cure for them. And I applaud your work."
Thank you.